Welcome to this sponsored session, Cracking the Tricuspid Code, the Bicaval revolution. And today we're going to explore how TricValve is changing the landscape where other therapies actually fail to treat our patients. And we will go from feasibility to more real-world data, and then from complex cases to patient selection, and finally to the guidelines. So I think we have an expert panel here. We have Rishi Puri, Matthew Price, Victoria Delgado, Philip Nicolai, and some guest speakers that will come on stage soon. So I think we should start because we have a packed program. So Rishi, please show us some new data from the feasibility trials in the United States.
Thanks, Martin, and thanks for everyone for being here. It's in the evening here. It's great to be at London Valves. So we're going to talk about some early data from the early feasibility study in the US. So we know that the trial portfolio for TricValve in the US is emerging. We did a number of compassionate use cases to get some early experience with this device, a little behind our European colleagues who already had 2 or 3 years of experience. We're in the midst of the EFS, which will probably be the largest EFS that I can remember in contemporary era. We are able to actually enroll up to 110 patients, not 80, across 50 sites. And in fact, now I think we've treated nearly 60 patients. And we're in late phase discussions with the FDA. As you can imagine, this has been a very rapidly evolving space with the approval of TriClip and Evoke. And so the trial design has had to be iterated to catch up with the evidence. So we're very close to having a final pivotal trial approved by the FDA. And this is planned to be a randomized trial 2-to-1, much like Evoke, 2-to-1 in terms of treatment of patients with TricValve to GDMT, 60 sites, and probably up to about 430 patients. And there may be a third arm for the more complex patients where we still think there may be a benefit in treatment. And so thus far, we have a fairly broad representation across the USA from key sites around the country who are now gaining a lot of experience with this technology. The TriCav-1 early feasibility study is really, as the name implies, it's looking at early safety and some early efficacy signals where we're looking at the usual safety endpoints that we're used to looking at in tricuspid trials. And we're looking at efficacy not only at 30 days, but we're tracking these patients at 3 months, 6 months, and yearly out to 5 years. And so thus far, this is a little out to date. I think we've implanted a couple more recently. We have 60 patients treated to date. And when we look at the screen fail, so this is the first time the company is formally coming to the US. And what we're learning in America is the vena cavas are bigger in America than in Europe, especially in Texas. And so most of the screen fails that we're having at the moment appear to be anatomical. And that will be remedied by the introduction of the 41 millimeter IVC valve that should appear at the time that we're going to start our phase 2, or the TriCav-2, which is the pivotal trial. And so here is some of the baseline data. These are sick patients. These are sort of relatively high Euro scores. Remember, the Euro score sort of underestimates the risk a little bit in these tricuspid patients. The Tri score is nearly 5. Almost all of these patients are fairly advanced at NYHA 3 to 4. Remember, Triluminate, half these patients were NYHA 2. These are patients who have elevated or dysfunctional kidneys, very elevated NT-proBNP levels, and there's not an insignificant proportion of patients that have ascites, sort of advanced congestive hepatopathy, RV dysfunction, and gross evidence of right heart failure. And so the procedural results thus far are fairly impressive. Many of these procedures for many of these sites was the first time they ever touched the technology. And so for a first look at this technology in the hands of US operators, we're seeing very high levels or rates of successful deployment without any emergency surgery or reintervention, and thus far we have no procedural mortality. We're still getting some data, so this is all very early, and this will become more solidified once more patients come in. So what you can see here is at baseline, most of these patients had a relatively preserved ejection fraction. TAPSE is in the normal range, and as are some of the other RV indices of RV function. And we want to introduce this term caval reflux. Remember, this is a caval technology. that is where the valves are placed in the heterotopic position, so we do not directly deal with the tricuspid regurgitation in the tricuspid valve. We're sealing off the cava to eliminate caval reflux, and I always say when I give these talks in TR, it's the R that causes morbidity and mortality, not the T. So if you can actually, it's not R on T, but if you can get rid of the R and eliminate the peripheral edema and the systemic congestion, you can help the patient. And we've known and we've seen data where forward flow goes up acutely, cardiac output goes up acutely, and on volumetric CT analysis we get reverse RV remodeling. And we'll perhaps talk about that on the discussion. But at baseline, all of these patients by definition should have reverse hepatic flow and caval reflux. And so at 30 days, we're starting to see some interesting data come out where we have preservation of LV function, RV function, and we're dramatically improving the severity of the caval reflux at the level of the vena cava. In terms of major adverse events, this appears to be a very, very safe procedure. Remember in the pivotal trial of using Evoke, we had a procedural death rate of around 3.5%. We had bleeding rates that were 14 or 15% and pacemaker rates of 25%. We're still learning how to implant this valve in the US, and we're having this is a fairly safe, streamlined procedure where with very low rates of bleeding, only one valve and two valve and valve procedures, usually it's the IVC. So we're very happy with the safety profile. There are no strokes, no pulmonary emboli, no pacemakers, no renal failure, no cardiovascular death, no myocardial infarction, no migrations, no thromboses. This is very good at 30 days. This is emerging. This is very early data. And so we need to take this a little bit with a grain of salt. This is going to become fleshed out in the next 3 or 4 months. And hopefully by one of the conferences early next year, we'll be able to present to you more solid data in a large proportion of patients. But we're seeing here that more than 80% of these patients are demonstrating or describing an improvement in one or more of the functional endpoints, whether it's NYHA, whether it's KCCQ, or a 6-minute walk test. And we're seeing here, again, this is limited data. We've got reasonable data at 30 days. We have some data at 3 months and a little bit of data at 6 months. But we're starting to see at around about the 3 to 6 month inflection point, when you have time for reverse RV remodeling, that seems to correlate with the KCCQ improving. And so this is exactly what the European investigators have been seeing, not only in their CE mark trial, but also in the expanding experience with over 3,000 implants. So to conclude, TRICAV-1 will enroll 110 patients across 50 US sites. TRICAV-1 will consolidate US operator and US heart team TricValve experience and device management in patients with right heart failure. We have to remember, this is a right heart failure therapy. So we cannot ignore the importance of the heart team, our heart failure specialists, and being good physicians, not just implanting and forgetting about the patient, managing the patient with right heart failure. We're going to establish an extensive safety record, an extensive mechanistic imaging portfolio that Nadira and Joao are leading at Minneapolis Heart Institute. We're going to allow insights for patient selection and procedural optimization, how to really nail the procedure, get the best seal, and we're going to set the scene for the pivotal trial. Thanks for your time.
Excellent. Thank you very much for this beautiful overview. We're going to have some discussions later on. I first would like to ask to get Angel to the stage. So we have seen some feasibility studies and data already, but let's scale up a little bit to go to the Bicaval, which is a little bit larger registry, to get some real-world data. So please, Angel.
Okay, thank you so much for the invitation to be part of this very good symposium. I don't know. Okay. So we know that around 1/4 of the patients that we usually evaluate for TricValve repair or replacement are not good candidates for orthotopic repair or replacement. So is CAVI a good solution, a good alternative for these patients? In this series of 644 patients who were submitted to the company for evaluating the TricValve, the anatomy of TricValve. So we found that the vast majority of the patients, nearly 90% of the patients, were anatomically suitable for TricValve. So it's a good solution for these patients that are bad candidates for orthotopic repair or replacement. The second question, what is the current target population for CAVI? According to the data from the Bicaval registry, patients we treated with TricValve had many more comorbidities. They are in an advanced stage of the disease, and as it's shown, more hospitalizations, worse renal disease, more severe TR, more elevated, the more elevated BMP, and a worse functional class. So the Bicaval registry included 204 patients from 27 hospitals, with the vast majority of the patients with massive or torrential TR and with signs and symptoms of right heart failure. And there were high-risk patients. The majority of the patients have an intermediate or high-risk TRIA score. So at 1 year of follow-up, the functional class improved significantly, and also the signs of right heart failure, as long as the hospitalization rate decreased dramatically after 1 year. And also there was a significant reduction in the pressure in the IVC, as you can see in the picture. The basal big wave in the IVC at baseline was 24 millimeters of mercury. After TricValve implantation, drop to 12 millimeters of mercury, and also we can see the flow in the porta and renal veins improved, and suggesting that there are less hepatic and renal congestion. So in the registry, the procedural success was very high, 96%, and the mortality at 1 year was 18%. But does TRIA score can predict the mortality at 1 year? Yes, it can. So the mortality was higher in patients with intermediate or higher TRIA score than the low TRIA score risk. And also we know that patients with advanced functional class and also with renal and hepatic dysfunction and ventricular dysfunction, there were the main independent risk factors for in-hospital mortality. And also we evaluated the patients from the registry. 35% of the patients had pacemaker leads, the pacing leads or ICD leads into the right chambers. And the procedural success was very high, 97%, was similar to the patients without leads. And also, even though these patients had more comorbidities, more coronary artery disease, more renal dysfunction, more hepatic dysfunction, and also more left and right dysfunction. But at 1 year of follow-up, the all-cause mortality and hospitalization rates were similar. Patients with pacemaker leads and without pacemaker leads. And also, it's a safe procedure. So there was only one patient with lead dysfunction after TricValve implantation that who require a new pacemaker lead. So it's a very safe procedure in patients with leads. And finally, we evaluated 39 patients with prior tricuspid intervention, either surgical or transcatheter. There were a very high risk patients, almost all the patients with TRIA score, with intermediate or high TRIA score risk. But as we still observe a reduction in the signs of right heart failure and also a significant reduction in the heart failure hospitalizations at 1 year of follow-up. So to sum up, TricValve is applicable a wide range of patients and anatomies. The patients treated with TricValve have a high burden of comorbidities and are in a very advanced stage of the disease. Heterotopic TricValve offers a clinical improvement and reduction in heart failure readmissions, and also TricValve is a safe and effective system in patients with leads and those with prior tricuspid valve intervention. However, to avoid futility, I think we need to assess carefully the patients, the RV function, the hepatic renal function, and also the TRIA score. Thank you so much.
Thank you very much. Excellent overview. And I would like to do some discussion. We have some time. So first of all, I would like to go a little bit into the safety profile, because both your studies show amazing results. I think really low risk of procedure. So what, in your opinion, really determines why this procedure is so safe?
Yeah, I mean, perhaps, if I could start. So, European have a lot of experience, and the technology was initially applied in very, very sick patients.
Yep.
And despite the fact that these were multi-morbid patients with coagulopathy, liver disease, very elderly, our European colleagues were able to demonstrate very good results in really what almost began as a palliative care population, and that's how we started our compassionate use program in the United States. So when we now take that a little forwards in terms of bringing the risk profile down to sort of more normal trial patients, and this is what we're seeing in the US, is that even with centers or operators who are naive, large bore venous access, following some simple rules, a very fluoroscopic guided procedure, no fancy maneuvers, no real reliance on complex imaging, and really just having a good surface echo subcostal in a procedure that is really sort of local anesthesia, no outline, no TE, very controlled. The longer you take, the company say, the better it is, because this is not Speedy Gonzalez, not a race. If you can get large bore access and push a catheter up a vein and follow some basic rules, you can do this procedure.
Yeah, very good. Engel, anything to add to that?
I totally agree. I think the workflow is similar to the TAVI. You need to evaluate the CT scan, and the procedure is a straightforward procedure. You don't need a good imaging, and it's a fluoroscopic guidance and also with a transthoracic echo guidance. And it's a very safe procedure. It's a straightforward procedure, and I think the learning curve is shallow. You can learn how to do it in maybe after 1 or 2 procedures.
Yeah. And maybe the eligibility, because we already saw a lot of patients were already suitable. We have the 41 valve coming up in the study as well. What do you think? Because
I mean, I think we're going to be able to enroll more patients in the rest of our. Well, the 41 will come for the TRICAV 2, which is a pivotal. But we're really only, when you look at the pivotal trials for Edge to Edge and Evoke, even with the experience and with some evolution, after consenting, your randomization rate was 20% in both the trials, right? After consenting. Yeah. So we're already getting a lot out. And so, we're about 50% already, and we don't yet have the valve size tailored to the US CAVA. Yeah. And so I think it sets the scene for a good proactive pivotal trial. Yeah. And hopefully, we can position this technology a little more on a level playing field in terms of who it could be applicable for and help.
Yeah. Good. And maybe looking at this data, because early feasibility studies, we have now larger registries. Which patients for you stand out? Which will be the best patients to perform? Where you really see it, okay, these stand out, these are patients we really want to treat with the TricValve, and maybe once you want to stay away from. Do you already have an idea? Maybe from you, but maybe the others look at the data as well.
I think the best patients are the patients that we have trouble for treating them with orthotopic repair replacement. For me, patient with pacemaker leads, patient with a huge annulus, and also the clinically we can treat patients with RV dysfunction. And it's difficult to treat patients with RV dysfunction with orthotopic replacement. So I think patients who are not suitable for orthotopic repair or orthotopic replacement, they are the best candidates, but also patients with RV dysfunction, patients with pacemaker leads, and also patients with previous tricuspid intervention, as I've showed a few minutes ago.
Yeah. I think so. Very nicely showing indeed. The CAD patients is a difficult group. We have a lot of trouble with, especially with T-tear or anything. With transcatheter replacement, sometimes it can be jailed or anything, but also sometimes giving trouble. So I think this is nicely showing that it's an option for these patients. So thanks a lot. We'll get back to a little bit more data later on. But I think for now, we have seen some evidence, but I think also complex cases teach us something. And Matt is going to show us a complex case where we performed the TricValve. So Matt, please show us.
You got it. Great, thank you. Thanks for the opportunity. So I was asked to present a complex case, and as Rishi mentioned, these cases are very straightforward. So to find a complex case is challenging. So I chose a case both of a complex patient and also a case that I think demonstrates how forgiving the procedure is and the technology is with the variability in the vena cava anatomy. So this is a patient who was initially randomized in the Triluminate trial by a small, somewhat wealthy hospital a little bit north of San Diego. And very early after the procedure, this patient had a SLDA. They attempted a single triclip and obviously had recurrence of his TR. And actually, his family reached out to me and asked me if I had the TricValve available. And at the time, I didn't. It was coming. It was always coming. So we didn't know when we would get it. So I had him come down and see me, and I did another triclip procedure where I put 3 XCWs along the septal anterior coaptation plane with a reasonable result. You see a large AP gap still, but he got down to, I would say, moderate TR. But unfortunately, just over time, the TR progressed, and this is about, I would say, 8 months to a year later. He now has severe fatigue. He's feeling worse. He has edema. His RV is not perfect. The TAPSE 14, and you see a glance here of the severity of his TR and his hepatic vein flow reversal. So I screened him for the TriCav-1 clinical study. And this is the CT workup that you get. And I want to also point out what Rishi mentioned about the screen fails for other trials, is that we don't, at this point, we're not pre-screening the CTs because we're still learning how to look at them, as opposed to other technologies where we can pre-screen before we formally submit for evaluation to the eligibility committee. So what you get is measurements of the SVC and IVC. This is the SVC measurements along the breadth or the length of the SVC from the confluence of the brachiocephalic and the IVC all the way down to the RA-SVC junction. And you put together these numbers to come up with the size of the valve and also the positioning. So this fit a 29 millimeter valve. Now, some things I want to focus on is the diameters at the pulmonary artery. So what we're going to do when we deploy the SVC valve, we're going to put the belly of this valve at or above the pulmonary artery, because that actually acts not only as a fluoroscopic marker for placement, but also to a fixation point for the valve itself. But the challenge here is that the numbers, the diameters of the SVC at the PA are quite large, so borderline large. You see the guidance for the middle of the PA is 27 to 34 millimeters for a 29, and this is 36. So it really flares right at the PA. So what you're going to need to do is locate this valve superiorly for sufficient compression and stability of the valve. You don't want it to move or embolize. And this may seem complicated, but it's actually not that hard. So, and also a point is that this patient had a mitral procedure and had an iatrogenic ASD, and I closed this first because, and Hal showed a great picture of the hemodynamics, is you get a ventricularization really of the right atrium. So you don't want a very high RA pressure then causing a right to left shunt. So here's the case. So what I did here, because I knew I had to implant the valve superiorly, or I wanted essentially the crown of the device at or above the brachiocephalic, is this is a straight AP view. I have a multi-purpose in the brachiocephalic or the innominate vein, so I can see the junction of the IVC and the innominate. I have a Lunderquist wire in the SVC, and I have a pigtail in the right pulmonary artery. That pigtail is going to be my marker for where I land the lower part of the valve. And now this multi-purpose catheter, which we don't usually use, this was just for this case, is going to mark the height, how superior I have to go. And you see here on the right, you can just barely see the multi-purpose catheter, and putting the crown just above that, and the belly, that center portion of the valve, well above the pulmonary artery. And this is the deployment, just a slow, gentle deployment. And you see here very nicely, fluoroscopically, I have a lot of compression of that belly, which is what we want. And again, even here, I could recapture the entire device and move it. And so this is released, and again, a good compression of the belly. From usually you see more of a belly and a narrowing of the bottom of the inferior portion of the valve, but here in this specific anatomically complex case, we want it to be more superior. And this is nice. I'm withdrawing the nose cone. You can see it's definitely well fixated. As we pull it out slowly, the SVC moves a little bit and then comes through without a problem. So we nailed the placement there. This is just an example of the IVC valve. So you can do this purely with echo. Here and fluoroscopy, here I actually have a pigtail in the hepatic vein, which will demarcate the junction of the RA and the IVC. You can give contrast. What I did here, which was quite nice, the sonographer did 3D transthoracic echo, so it can really delineate exactly how atrial the tip of the IVC valve is. You generally want it between about 9 and 11 millimeters or so. And then this is our deployment. I'm just still almost fully deployed. I could still recapture this IVC valve. I'm giving a little bit of an injection just to see the hepatic vein is nicely open. Here's a still frame of the echo that shows the distance from the tip of the valve to the IVC RA junction is perfect at 10 millimeters. And this is the final result. We have complete reversal of IVC flow and a very nice finding. So in summary then, CAVI with TricValve is a straightforward option for cases of TT or failure. And I think Angel showed in his presentation several patients in the European study, the Bicaval Registry, were failed alternative strategies. Sometimes you have to implant the valve superiorly based on anatomy to ensure device stability, but this is quite straightforward. And I think we should continue to explore ways to monitor how we're implanting that IVC stent, and 3D echo by allowing us MPR by aligning it very nicely to see the RA IVC junction may be a good way forward. And I will leave it at that. Thank you very much.
Thanks a lot. Thanks a lot, Matt. Beautiful case. I think we have a question from the audience first.
A question from the audience from Clemens Steblemnik, and they've asked, I think Angel, the in-hospital mortality was quite high in the European registry. What was the most common reason? So can you remember, the in-hospital mortality was directly proportional to your tri-score. If you had a low tri-score, your mortality was 0. If you had a high tri-score, it was like 8 or 9%, which is the equivalent of surgical TVR. So can you remember some of the reasons?
Yeah, I don't know if...
Can we mic in Angel, thanks.
And come up front, please.
Yeah.
Go.
Come up here,
Come.
yeah.
I think it's a very good question, and we included all the patients that we treated initially. Now we learn a lot, but the main cause of death were we treated patient in the end stage of the disease was a cardiovascular mortality, but not related with the valve, not related with the procedure. We treated the patient maybe it was a futile procedure.
Yeah.
I think just because it's a straightforward, safe procedure doesn't mean that patient selection is not important.
Absolutely.
So I think, Philippe, you're going to talk about that quite a bit, I think, about patient selection.
Yeah.
Absolutely. I have one question. Do you always close an ASD, iatrogenic or natural, before the Bicaval procedure?
So far I have, yes. And you?
No, we don't. So the thing is, we look exactly. We do all our procedures in general anesthesia, and we ask the anesthesiologist afterwards if we see a right to left shunt, and we ask the anesthesiologist, is there any decreasement of the saturation? Yeah, and if we see some decreasement of saturation, then we close it immediately. Immediately after the procedure. And this is one of the advantages of this procedure. You can enter the right atrium. You can do whatever you want in the right atrium also after this procedure. Yeah, you can do a mitral clip afterwards. You can also closure. You can do an LAA closure if you like to do this. And we have the experience that only in a very, very few cases where you have an iatrogenic ASD, you have to close it after the procedure. And in most cases, you can leave it and nothing happens.
So, I wish we could do this practicing freely in America, but we're in a very strict IDE trial at the moment. TricValve 1 and then onto TricValve 2. And so if you have to then do an additional maneuver after implantation, it is an endpoint. So you get penalized. And so in the confines of the clinical trial, if you have an iatrogenic ASD in screening, we'll ask you to close it and we'll wait 30 days to show that you have a seal. If it's a PFO, it really does depend upon if there's a bidirectional shunt at baseline, and then it's a bit of a dealer's choice. But for an iatrogenic ASD from a previous AF ablation, any left-sided procedure, we will ask the investigators to close a priori.
I think also that for any tricuspid procedure, if it's an IASD that's lasted a while, say more than a year, it's not going to close. Just to lower the volume on the right side is probably a reasonable thing to proceed to do, and it's an easy procedure. So, but I think it's worthy of study.
Okay, for the sake of time, we have to move on. So we move to Philip. So we had some difficult cases now, and Philip's going to zoom out a little bit more to some bigger data from the TricUS registry. So and some long-term data as well. So Philip, go ahead.
So it should start now. Yeah, thank you, Martin. I want to show you a little bit of our data from the European registry, and also a little bit about patient selection. So these are my disclosures. So we heard about the devices and available devices in Europe. So we have a very low rate of screen failures also with the IVC 35 device. So in Europe we don't need to have the IVC 41 device. And the interesting part against Angel is that we look exactly for the patients that are really eligible to close the tricuspid regurgitation from grade 5 to grade 0. And as we started with this device, we thought about this end-stage patients, about this patients where nothing works, about the patients where we have a high pulmonary pressure, low RV function, and I can say from our experience, don't treat these patients. These end-stage patients are really the end-stage patients, and also not for the Bicaval devices. So, and this is how we select our patients from a hemodynamic perspective. So we start, if we have this TR grade 3 to 4, we look for the PA pressure in the right heart cath, and if we have a precapillary PA pressure or a precapillary pulmonary hypertension, pulmonary resistance more than 3 Wood units, we bring them to our pulmonary hypertension specialist. We don't treat them, especially not with an orthotopic or heterotopic device. And then it goes to our heart team, and we look for the RV-PA coupling. If it's more than 0.4 and the PA pressure should be less than 55 millimeters of mercury. The problem is that we learned that we underestimate also the pulmonary pressure in the right heart cath. So it is hard to understand, but sometimes we see in this torrential tricuspid regurgitation cases, we see a right heart, a PA pressure of 30, and if we implanted the Bicaval devices afterwards, we have a PA pressure or an RA pressure that equals in this torrential tricuspid regurgitation the RV pressure. We have an immediately increasement of the PA pressure during the procedure. So we know that if in these cases we have to have a safety margin, TR4 we add 10 millimeters of mercury, TR5 we add 50 millimeters of mercury to the invasive measured PA pressure. And also the TAPSI is not everything. So if we have this type 2 contraction where we have a more circumferential contraction and no this longitudinal contraction of the right ventricle, we have also to evaluate the right ventricular function. And if these everything is good, then we think of a valve repair. It's also a good thing. And then we look for the edge-to-edge repair if it's with a good result, predictable. And if we have no good RVPA coupling, then we look for TIR palliative or conservative treatment. So from my perspective, I would not recommend to really treat the patients, the end-stage patient, with a bicaval device. If we have a good RVPA coupling, a good hemodynamic system, then we can do everything and the full cycle CT, and then we look for heterotopic or orthotopic valve replacement. And on my next slide, I can show you the decision about these devices. And this is in our hospital. Yeah, this is not very scientific, but if we have a low RVPA coupling, then you can do TIR, but don't do any valve replacement. And we think that the bicaval, the heterotopic valve device, is equal on the level with the orthotopic valve device. If you have bad imaging conditions, it's absolutely good to have the TricValve. If you have ICD leads, we see some problems in TIR, we see some problems in TTVR, but TricValve, it's not a problem. We showed this in our data. Also pacemaker leads. If we have very large annuli with a large central gap, also TricValve can be the solution. Complex anatomical situation with a glide score more than 2, you have not a perfect result with TIR. You can do orthotopic replacement. You can also do TricValve. Yeah, and for example, what we discussed, the failed TIR, the partial leaflet detachments or the bad results after TIR with a good ventricular function is also a good thing for the TricValve. TTVR may be helpful, also re-TIR may be helpful, but TricValve, it's absolutely easy. And yeah, as I show in my data, it's a good result. So this is the procedure we saw this in the last slides. What's also interesting is that we see an immediately hemodynamic effect during the procedures. We ask our cardiac surgeon, our anesthesiologist, immediately after the procedure, how behaves the blood pressure, and we see an increasement of the blood pressure, and this goes equal with a retraction of the pigtail catheter from the RA to the IVC. Yeah, Angel showed this. These pressure drops, and this shows us an immediately hemodynamic effect of these patients. So from the TricValve registry, yeah, we have at the moment 107 patients in 36 sites. We want to go to up 450 patients in 100 sites, and also these are very ill patients. We have a prior pacemaker implantation, 20%, and it's in all other studies. Yeah, the most patients are secondary tricuspid regurgitation, 15% primary or organic tricuspid regurgitation. So Euroscore is not so high, but we know that the TriScore is more predictable for the outcome. NYHA class 3, 70%, so as in all other trials. The major adverse events also in this very, very sick population is extremely low, and we have also a very, very low onset of new pacemaker due to TricValve implantation, so it's nearly zero. Yeah, we have a very, very low pacemaker rate. The all-cause mortality in this very sick all-comer study is 11.2% at 1 year. That's low, and the freedom, and this is impressive, from heart failure hospitalization in this very sick patients are 80%. Also, from the clinical results, we have at the moment 67 patients in a 1-year follow-up and only 32 patients in a 2-year follow-up. So the patients are growing up at the moment, the procedures are growing up, so we have to have a long-term result. But we have still a very, very good, as in other devices, long-term result from a clinical side, and also the quality of life improves, and also the 6-minute walk distance. We have to have more data, we have more patients in this study, and we have to have a longer follow-up. But I believe this is really a good device for treating our patients, and from our side it's equal to the orthotopic replacement. And now I'm open for discussion.
Good. For the sake of time, I would like to ask Nadira already to come up front, and I have a short question for Victoria. We saw the RV function cutoffs being taken into account, and we now have cutoffs in our guidelines or anything. So, when you're doing the evaluation for these kind of patients, what are you looking at? Is it important as for TTVR or anything when you're doing it?
I think that is important because it's probably the main marker to determine the prognosis of these patients, and you don't want to have a right ventricle that is not going to function later on. How to do it, and if those cutoff values are the ones that are correct, are safe, mainly safe. But basically, all the parameters that have been tested are in terms of all-cause mortality, and what you want to see also is if the therapy is going to alter the natural history of that disease. And what we don't have and we don't measure is the contractile reserve, which is different than the function. And you can see that when you remove the congestion, which I think that with this device you accomplish that, many people and the trials have shown that you need to eliminate the tricuspid regurgitation, but basically the consequences of that tricuspid regurgitation, because the patients improve also symptomatically, quality of life, and then you can alter the natural history of the disease. And later on, we will need to see how that right ventricle recovers, because then we determine the contractility, the contractile reserve.
Yeah, perfect. Good answer. Nadira, show us a little bit more on the daily practice and the guidelines to end up with.
Thank you very much. Good evening, everyone. Thank you for having me. And it's my great pleasure to actually talk about the TricValve best practices and how it's implicated in the current ESC valvular heart disease guidelines. These are my disclosures. As you've seen last month, the ESC valvular heart disease guidelines, I really applaud the ESC group really highlighting the importance of treating tricuspid valve regurgitation at an early stage. You've heard previous presenters, these presenting to TricValve very late. We need to do better. The fact that when we look at cardiac imaging to see if there's any dilatation of RV, then you can see the referral much earlier in terms of any tricuspid valve intervention. And really applaud in terms of increasing the classification of tricuspid valve intervention to 2A and Class A. So really exciting for us, and we imagers need to do better in identifying. There's a huge landscape of TTVI. You've seen in all the other symposiums and in this arena as well. But heterotopics certainly have a place in the TTVI. And so the best practices, you heard you want to reduce congestion, you want to increase cardiac output, increase KCCQ, reverse remodeling, which we have seen, decrease the annular size of the tricuspid and decrease the coaptation gaps. So I want you to think about how about TricValve as a potential first-line therapy or even as an adjunct to the current therapies, commercially, repair or replacement. So think about it. And what the previous speaker and Dr. Delgado mentioned, the right ventricular function, is very important. The implications in terms of when you repair it, it does affect a little bit, but certainly replacement in your experience has its effect on the RV function. We need to do better, and understanding like what Dr. Delgado has mentioned is a contractile reserve. And we know the physiology of RV, it's complex. I call it the croissant. You want to restore the croissant. That's what I tell my fellows. Yes, contraction of the longitudinal fibers, you have movement of the free wall towards the septum, and you have traction of the free wall as well. There's a lot of factors thinking about the RV, not just elimination of the TR. And if we can reduce the hepatic congestion, I think it can help. I'm a cardiac imager, interventional echocardiographer in Minneapolis. First line of imaging is certainly bread and butter echocardiography, but the parameters can be very challenging in echo. So we use CT as well for RV function. This is by one of our research scholars, using it not just anatomical, but also as a functional assessment in terms of deciding whether we need to repair or replace, right? In a lot of the clinical trials too. Cardiac MRI, truly a gold standard in terms of TR, in not only quantification, but RV function, as you can see. So think about the best practices. Can we do all comers of RV for the TricValve? Does the TricValve has any impact of RV function, which we'll ask the panel and also later on. Second part of best practices, the hepatocaval reflux. Do not underestimate it. Myself and Dr. Cavalcante in Minneapolis are trying to understand the pathophysiology of this. Look at the baseline, you have reversal. And post, you have complete elimination of the hepatocaval reflux. Do these patients feel better? Probably that's the reason why. Reduce that congestion. What happens to the effects of normalization of the hepatocaval reflux? So we are going to understand this much better in the pivotal trial. And the third best practice, TricValve as a first line or adjunct. Change the concept, then rather as a palliative. So the current article, I saw this in terms of algorithm of tricuspid valve. You see caval medical therapy at the bottom left, as palliative. As you have seen from all the registries in Europe, they are all sick patients. The mortality is high. I think we need to change this. Get these patients in early. You can use the cavi. And then I like this slide because what is the beauty of TricValve, right? You can do it previous tricuspid valve interventions or surgery. You can do it in existing pacemaker. It's easy from imaging, from my perspective, transthoracic, or sometimes TEE if your transthoracic is hard. It is 100% no footprint on your tricuspid valve or your annulus or your leaflets. You can do it conscious sedation. It's easy on your imaging, as I mentioned. In addition to that, long-term data as they present a minimal to zero halt experience with standard OAC's conditions, so you have low rates of thrombosis. And so, in conclusion, the best practices to take home from this symposium. Number one, think of it as a first line or as adjunct to other tricuspid therapies. You preserve all the future options for your tricuspid valve for these patients. As we have seen, you've seen the cases presented, the durability of the other technologies. We do have to think the other toolbox in the tricuspid valve intervention. In addition, this therapy, I think, can really be applicable to all patients, irrespective of the RV function, which we'll discuss further. And most importantly, like any other intervention, it helped reverse remodeling, increase the forward stroke volume. So really, TricValve favors all complex anatomies of tricuspid valve, its ease of use, the scalability of the procedure, which is most important, the mass scalability, and is efficacious. With that, thank you very much.
Thank you very much, Nadira. Excellent talk. And I think we indeed have to get rid of the idea that it's a palliative treatment. I think it's an option, and actually is an option for a lot of patients because it simply is something where other therapies fail, and that's immediately where we need to think as TricValve as an option for these patients. So thank you very much for that. And I think we're out of time, so thank you all for being here. And I think we nicely showed that TricValve is a solution for a lot of patients, and a lot of patients in need that can get other treatments. And I think we have seen more evidence, more confidence actually, and I think the enormous need will provide us more data over time. And I would say let's continue the revolution with the Bicaval stent. So and let's see you next year. Bye.